And then the last one on the ulnar side, Tom, is the TFCC, is a stress test. So again, thinking about that differential diagnosis on the ulnar side, but what test can we consider? So pain in this region can actually come from various structures, so it's not really easy. But one of the things to consider is your TFCC, so your triangular fibrocartilage complex. And the word complex, again, is a reminder there's various structures. So let's try and do some differential diagnosis. If you're thinking about the discus, think about like a meniscus of the knee, it's something that will respond painful to compression. One sign you can do is the Fevea sign, where you can actually press in this region. So you are between the two bones, your triquetrum and your ulnar styloid, and between your two tendons. So you've got your extensor carpionaris and your flexor carpionaris. So sweet spot in there, if you press in there, might be tender. Obviously, again, you're comparing it both sides. If you're looking again at TFCC, some of the things you can do then is compression, and you can almost do like an orange squeeze effect. And then if you really, really want to stress this area, you can grab it like a handshake, you can put some compression, push into it, and literally like scooping the bottom part. So it's known as a scoop test. Okay, so that's for the discus. Now, if you're looking at some other structures to consider out of that complex, think about your distal radial ulnar joint, your DRUJ. So again, one way to do it is if I'm holding the radius and all the hand, if I'm moving that ulna, okay, you can see it should be moving, it's normal. If I do full pronation, where I've locked the joints, close back position, does it feel stable now? Does it feel like things have stabilized rather than they're very moving? So again, that's really good looking at your distal radial ulnar joint. If you're looking at the collateral ligament as part of the structures, if you're trying to stress it like you do to fingers, you're probably going to hit the bone before you stretch the ligaments. So one of the things you can do there is, rather than try and do this stretchy thing, is think, okay, the ligament attaches this bone, so you're looking at forearm and hand. So if I move it, okay, so I'm stabilizing the radius, I'm stabilizing the hand. If I move that styloid, a bit like a piano key, up and down, okay, what happens now? If I move the hand into more radial deviation, it should be tighter now. Does it have that same? Oh no, nice and stable. So moves more, moves less. So again, that's telling me that the ligament is doing its job, and I'm seeing whether there's any provocation of symptoms also. And one of the questions you asked before, Tom, which we've probably covered on the radial side, is the value of scanning. Well, there's this nice paper which actually was published this year, which looked at the diagnostic value of MRI in your TFCC complex. And what they found is that there was a very good diagnostic value of MRI where it came to TFCC injuries, if using the Palmer's classification. Now, what's the Palmer's classification? Simplistically, you've got two classes. You've got traumatic, you've got degenerative. And so what they found is that using that classification was actually really good. But there's always a caveat in the story. The caveat really is that for central tears, it's probably really, really good, really accurate. For peripheral tears, we've got many subclassifications, and one of them is the ATSACE classification. There's a nice paper which is actually all the way back 2011 by Atze and Lecati, and if you look at it, it is complicated, but it tells you the complexity of the peripheral tears. And basically, what these two studies are telling us, obviously you've got the classification from Atze and Lecati, and then the paper we just talked about by Zoe and colleagues in 2024, is that when you're looking at peripheral tears, you won't detect everything. And so that's where arthroscopy remains your gold standard. So is that difference, again, in anatomical location? Is it more of a central tear? Is it a peripheral tear? And what can an MRI tell us? And it's got great accuracy, but also limitations too.